This video is about life after GP training, making choices in sessional GP work, and it will cover indemnity, working in different settings, superannuation, how to access support, career breaks and the retained GP scheme. I'm Paula Wright. This video is part of a series of 3 videos. The other 2 videos cover the salaried aspects of GP work, so the green boxes, and the other video covers locum work, so the blue boxes. This video covers areas relevant to both those roles, and those are the areas covered in these brown boxes. Your GP training is geared up towards you taking a partnership after qualifying, but a significant proportion of the workforce will work in other roles, non-contractor roles, which include employed GP roles or self-employed GP roles such as locums or out-of-hours doctors. I've made 2 separate videos covering the more detailed aspects of both of these aspects of GP work. So there's a video on salaried work and one on locum work, but this presentation covers issues that are generic to both. One of the things it's important to appreciate is that when you decide to work in a particular setting, you may be narrowing your skill set. So if we look first at general practice, the green column in the middle, when you're working in a traditional practice, you're using a range of skills like chronic disease, acute general practice, visits, palliative care, contraception, telephone triage. Looking to the left at locums, you will probably get less experience of chronic disease, palliative care and telephone triage. If you go to a walk-in centre, you might get a lot less exposure to chronic disease and indeed no exposure to visits, no exposure to palliative care and very limited exposure to contraception, and there won't be any telephone triage. Looking towards the right, working in a hub which is part of extended access, again there's no chronic disease, no visits, no palliative care and usually no telephone triage. And then in the out-of-hours setting, again there's less chronic disease, but you may have some palliative care and you certainly can do visits. So it's important to realise that when you choose one of these settings you may de-skill in certain areas. General practice offers an amazing range of opportunities for GP. So aside from your clinical role, there are non-clinical roles in management, commissioning, CQC, NHS England, education and appraisal, and then there are many clinical roles which GPs may often develop in parallel, such as being a GP with special interests, for example in dermatology, doing secure medicine in prisons, family planning, occupational health and so on. The GP role itself can be very varied, as we've just explained, because of the different settings in which you can use those skills. We've seen a significant change in the way indemnity categories are organised. So traditionally there was in-hours, which is in green, usually on weekdays between 8 and 6:30, and then there was the out-of-hours category, which was generally classed as higher risk. So the current categories have changed, particularly with the development of hubs or extended access hubs between 8 and 8. This means that the low-risk category of in-hours is now called scheduled care and operates 7 days a week, providing 3 conditions are met. There's access to the full medical record, the appointments are booked rather than walk-ins, and the patients are registered to local practices. Everything outside of this, so before 8 and after 8, is considered unscheduled care. It's important to remember, however, that even within the 8 till 8 band, 7 days a week, you might be working in a setting where the work is considered still unscheduled. And this is if any of those 3 categories are not met, i.e. patients are not booked, or you don't have access to the record, or the patients are not registered with the local practices. Before taking out any indemnity cover, you need to make sure that you understand the setting in which you work and you discuss this work with the MDO that you're in contact with. This slide shows the different settings in which a GP may work and the rough categorisation according to scheduled and unscheduled care. But remember, it's important to check with each MDO whether the setting you're working in is covered by their scheduled or unscheduled category. It's also important to realise that some roles are increasingly covered by trust indemnity. So particularly a GP working in the emergency department may be covered by trust indemnity, and some practices, part of super practice or larger organisations, may also be covered by trust indemnity. Also, certain out-of-hours organisations are now taking out insurance instead of indemnity. All GPs are required by the GMC to take out adequate clinical negligence cover, and this can be provided either through traditional indemnity or through newer insurance packages. Indemnity has a long history with the three main organisations, and it usually includes cover against GMC investigations and criminal investigations, and is what's called occurrence-based. This means that providing you are paying premiums at the time that the clinical event occurred, you are covered no matter when the claim comes in, even if it's many years later. On the downside, it's considered to be a discretionary cover which can be refused. From the insurance point of view, this is usually described as contractual rather than discretionary, and it's often paid for by the employer. On the downside, it's what's considered to be claims-based cover. This means that the premiums have to be being paid at the time that the claim comes in, not you won't necessarily be covered just because premiums were being paid at the time that the clinical event occurred. So if these premiums are paid by your employing organisation and you've left or have retired and the organisation has ceased paying those premiums, you may be very exposed. There's generally shorter run-off cover. The payouts are capped and there may be exclusions, and there's often a requirement to notify an event that may potentially give rise to a claim. There's also the issue that the interests of the employer may be in conflict with the interests of the employee. In the event of a clinical problem, it may not be in the interests of the employer to safeguard the reputation of the employee where this is in conflict with the reputation of the organisation. Because this is a complex area, I want to draw your attention to important guidance on the BMA website. Firstly, medical indemnity guidance for GPs, published in May 2017. And also this blog written by Dr. Krishan Agrawal, covering a number of new areas of indemnity that have arisen over the last year, and particularly the contrast between indemnity and insurance. Both of these are worth a read. An important concept to get your head around when you qualify is the concept of the pension tiers, as you will need to determine which tier your work gets superannuated at. And this depends on whether your roles fall under practitioner roles, where the tier is based on your actual income, or whether your roles are officer roles, where the tier is based on your whole-time equivalent income, regardless of the hours which you work. So let's look at some examples. On the green side, we've got somebody who's doing portfolio work. They're doing a series of part-time roles, working salaried, locums, appraisals, some CCG work and out-of-hours work, and their total income is going to be added up from those different streams of work. There's also an example here of somebody who's doing some hospital work, and their actual income is 14,000, and that's based on a whole-time equivalent salary of 75,000. They're also employed in an educator role on the vocational training scheme and are perhaps earning 18,000, which is their part-time income based on a whole-time equivalent salary of 90,000. So let's see which tiers they need to select to superannuate their income. Well, the practitioner needs to add up the actual income for each of those roles, and that total income then determines which tier that they're on. So their total income is 74, and that falls under the bracket of 13.5%. In contrast, these officer roles, so the clinical assistant role, the tier is based on the whole-time equivalent income. So even though they're only earning 14,000, they're superannuated on the tier relating to 75,000. So that's again the 13.5% tier. And again, the other role, the VTS role, is superannuated based on the whole-time equivalent income. So again at the 13.5 tier. And we need to look at the annual cycle for superannuation. So before each financial year, the practice will submit an estimate of pensionable profits for all salaried GPs, and this determines which tier the GP will be superannuated at. but we need to remember that that tier needs to take into account income earned outside the practice. So it's very important for portfolio GPs to inform their practice of their expected income from other practitioner roles, such as locums, out of hours appraisal, CCG work, and so on. The income is then deducted, the superannuation is then deducted at that tier for the rest of the year. And at the end of the year, there's a Type 2 practitioner form which is submitted at the end of April following the end of the financial year. And on this form you declare your actual income and the actual superannuation you've paid. And this is a way of ensuring that any overpaid or underpaid income is put right. So it allows you to pay arrears or to have an overpayment repaid. And it's important to realise that the pension record kept at the NHS Pensions Agency, it will not be updated until this form is submitted by you. So just to clarify, Type 2 practitioner is somebody who is either a salaried GP employed by a practice or APMS. It may be a long-term locum working in a practice for more than 6 months. It may also be somebody working for an out-of-hours organisation, which is not a trust, and this can be in an employed or self-employed capacity. When you work as a locum, you will need to use GP locum forms A and B, and these are obtained from the NHS Pensions website along with all the guidance. These are explained in more detail in my other video that specifically addresses the needs of locum GPs. You're entering general practice at a time when a high proportion of GPs plans to quit in the next 5 years. The average is 35% across the board, with 60% in the over 50s. There's been a dramatic rise in the consultation rates, particularly in the older groups of patients, and this has had understandably a big impact on workload. 84% of GPs say excessive workload is preventing safe delivery of care. If we talk about retaining GPs briefly, we can see from this graph that there are 2 peaks in GPs leaving. For females, there's a peak around family age, so the blue line shows quite high rates of leaving for women at around the ages of 35 to 39, and then another peak in the over 50s. For men, the main peak is later on in life, that's the red line, and very high rates of leaving over the age of 55. So the retainer scheme, which aims to keep GPs in general practice, has changed significantly from 1998, when the funding was £59 per session, which is around £3,000 per employed session per annum, with a professional expenses payment of around £300 per annum for the doctor, and eligibility was based on the need for part-time working and the intention to return. The flexibility to work outside the scheme was limited. Under the relaunched scheme, there's increased funding to incentivise practices to take on retainers, so this has gone up to £4,000 per session per annum to the practice for employing a retained doctor. Professional expenses have also gone up, reflecting rises in these costs, so the retained doctor is entitled to £1,000 per session per annum, and to be eligible you need to demonstrate that you intend to leave general practice, that you require educational support, and that you need additional flexibility that can't be provided through a normal salaried post. The scheme is more flexible in terms of allowing you to do work outside the scheme. Many GPs, when they qualify, are thinking of having a spell abroad and don't always appreciate that the routes to return are very complicated and may involve lots of assessments and uncertainty. So I'm explaining in the next slide some important choices that you face. So if you're thinking of going abroad and you're newly qualified, there are some things you need to consider. You need to be working actively in your area to remain on the performers list. The minimum number of sessions according to statutory regulations is 1 session a year. However, many areas enforce a minimum of nearer to 50 sessions a year plus an annual appraisal. So this is somewhat area dependent. So if you're thinking of going abroad for more than 2 years, one of the considerations is when to go. And there's a difference in your options depending on whether you stay and work as a GP for 2 years or you go sooner than that. So If you've already done 2 years as a GP after qualifying, then you have better options, because you can, for example, go away for up to 5 years working as a GP and then have the option of re-entering via the portfolio route, which is a route where you submit a portfolio, a bit like an appraisal portfolio, and have the potential to bypass lots of entry assessments. If you go away for more than 5 years, or your time abroad is not working as a GP, or you haven't done your 2 years working in the NHS, then your only option is to re-enter via the induction and refresher scheme and via the assessment route, which is with an entry MCQ and potentially a simulated surgery. If you went through the portfolio route, you then have a relatively short placement of 1 month, and then you return to practice. If you go via the assessment route, then you're looking at a longer placement of up to 6 months whole-time equivalent, and then return to the medical performers list and to practice after that. So most newly qualified GPs will have had some experience of being in a CSA group or CPD group, and it's strongly encouraged that you continue to access such a group after qualifying, because they provide essential peer support as well as a structure for ongoing CPD. In addition, for those GPs who are not part of a practice team because they work as locums, they're an important opportunity to discuss significant events for your appraisal. Additionally, you can discuss cases in these learning groups, and that provides a vital way to benchmark your clinical practice against that of colleagues. For maximum sustainability, you need to think about being in a group of 6 to 8 members with regular monthly meetings. If you live in the North East, you'll be able to find colleagues with whom to join up and form a learning group through the North East Sessional GP group. There are lots of national networks which you can access for support. The National Association of Sessional GPs has excellent online resources. There are some useful Facebook groups as well, such as Resilient GP and GP Survival. And then there are the networks and programs centred around the first 5 RCGP members. The North East has a Facebook group for Sessional GPs, which you can join, called Sessional GPs North East. And then there is also the North East Sessional GP group, which provides information about vacancies, education, peer support and networking. Other sources of support are also shown here. So what does NESG offer its members? Well, if we look firstly at education, there's a monthly educational programme run currently at the Freeman Hospital, which includes safeguarding children and adults and also CPR. The group also offers a means by which members can contact other members to form self-directed learning groups. Thirdly, the group cascades information via email alerts and the website listings page about educational events which are available in the region. The group provides peer support by means of its quarterly members meetings and also the monthly educational meetings, by means of its self-directed learning groups facility and also through its annual social event. And it provides information about work opportunities, vacancies for locum and other permanent work. And then there's also information which is provided via its web pages, its newsletters and through the informal network. I hope you found this presentation useful and that you enjoy the next steps of your GP career. Please feel free to share this presentation, and also I'd like you to consider following me on Twitter. I'd also be interested in your feedback to my NHSnet address. You may be interested in some of my other videos available through my YouTube channel, to which you can also subscribe.